This USMLE NBME podcast in which we discuss important questions. So let's get ready with this. Okay, now let's move on. Yes, so let's begin with it. Let me get my pen. Yeah, let's begin. Fine. Okay, so a 7-year-old A 7-year-old boy is brought to the office by his mother because of 1 month history of urinary incontinence. So the patient is having urinary incontinence since 1 month. So the 7-year-old boy is brought by his mother. During this time, he has also passed occasional hard, painful stools also passed this time. So the mother has what? He has not had pain with urination or changes in appetite. He has had occasional episodes of daytime enuresis at a school since he was toilet trained at the age of 4 years. Until last month, these episodes were rare. He has wet the bed 4 times weekly during the past month. His mother cannot identify any stressors at home. He has no history of serious illness and receives no medication. Vaccinations are up to date. He receives grades of A's in school. He is at the 25th percentile of height for height and weight and 35th percentile for BMI. Vital signs are within normal limits. Examination shows no abnormalities. Urine analysis shows no abnormalities. Which one of the following is the most appropriate next step in the management? C. The correct answer is administration of an osmotic laxative. Laxative because hard stools were there, right? So for that laxative should be given. Let's see the explanation in detail. Okay. So correct answer is A. Constipation leads to the formation of hard stools that can accumulate over time and apply pressure to the bladder, leading to urinary incontinence. Leading to urinary incontinence. Okay, so because of the constipation, the patient uh, was having urinary incontinence. Urinary incontinence. The patient was having urinary incontinence because of the constipation. Hard stools were there. Symptoms include daytime urination, bedwetting, urinary frequency and urgency. Urinary frequency and urgency or urinary tract infection. Okay, fine. So, see, constipation leads to formation of hard stools that can accumulate over time and apply pressure to the bladder into urinary incontinence. Symptoms include daytime urinalysis, bedwetting, urinary frequency and urgency, or urinary tract infection. A history of constipation in the passage of hard, painful stools is suggestive of this. Pediatric constipation is a common problem and is usually functional, although other causes such as congenital megacolon, Hirschsprung disease, spina bifida, hypothyroidism, cystic fibrosis, or diabetic insipidus should be excluded by a careful history and physical examination. Major signs that suggest an organic cause of constipation includes onset of constipation prior to 1 month of age, delayed passage of meconium, failure to thrive, abdominal distension, intermittent diarrhea or explosive stools, an empty rectal vault or tight anal sphincter, and midline air of pigmentary changes over the lumbar spine. Imaging and extensive laboratory testing are usually not necessary for most children. Treatment of constipation includes osmotic or polyethylene glycol based laxatives and dietary modification with increased intake of fluids and fiber. Okay, incorrect answer is ECD. Desmopressin therapy is a vasopressin analog. It is used for the treatment of constipation secondary to diabetes insipidus. So, because of constipation, there was urinary incontinence. So, we are prescribing laxative to smoothen it. Okay. So, desmopressin therapy. Desmopressin therapy is a vasopressin analog. Desmopressin is a vasopressin analog. So, it is useful for the treatment of constipation secondary to diabetes insipidus. Okay. Diabetes insipidus possesses large volumes of dilute urine, dehydration, thirst, and increased serum osmolality. So, because of diabetes insipidus, we give vasopressin analog, that is desmopressin. So, desmopressin is the vasopressin analog. It is given to diabetes insipidus patients to save the volume. Okay, because large volume of urine is formed. So, it is incorrect answer. Okay, so it is incorrect. Recommendation for use of a bedwetting alarm is a useful treatment for nocturnal urinalysis. Okay, but it is not helpful for the treatment of urinary incontinence secondary to constipation. The patient's history is of passage of hard stool, painful stool suggests that constipation is the primary cause of urinary incontinence. Renal ultrasonography is useful for the evaluation of hydronephrosis, vesicular urethral reflex, and congenital urinary tract abnormalities. It is seen in congenital abnormalities. Reassurance that this is a normal behavior is incorrect and will delay the treatment of this child. Sorry for that. Treatment of the child's constipation. Okay. Educational objectives. Constipation is a common pediatric problem and may lead to urinary incontinence as a result of external compression of the bladder. Okay. Constipation is usually a functional problem, but familiarity with red flag signs is crucial to excluding organic cause. Treatment of constipation include osmotic or polyethylene glycol-based laxative and dietary modifications with increased intake of fluid and fiber. Next. Okay. So a 14-year-old boy is brought to the physician by his a 14-year-old boy is brought to the physician by his mother because she has had difficulty awakening him in the morning. So a 14-year-old boy is brought to the physician by his mother because she has difficulty awakening him in the morning since the start of the school year 3 months ago. She reports that last year he would always get up on his own. She now has to rouse him several times every morning. She says that he has the same group of friends as he did last year. When interviewed alone, the patient says that during summer he discovered a talk show at 10 p.m. that he enjoys watching. He said that he is not tired at 10 p.m., which was his bedtime last year. Physical examination shows no abnormalities, so the following is most appropriate next step. Treatment is not required because it's just a circadian rhythm which is delayed for 2 hours. So slowly we can change that and everything will be normal. Question says, do you need urinary toxicology screen? No. Use of an over-the-counter sleeping medication as needed? No. Modafinil, zolpidem for insomnia? No, not required. Okay. So any medication is not required, but just the circadian rhythm maintenance is important. The child should avoid screen timing during night because of the excessive use of screen timing. Is not able to sleep early and get up early. That's completely right. So circadian rhythm is important to maintain. Otherwise, so here a demonstration of sleep pattern and behaviors are typical for adolescent because the patient is now 14 years. After puberty, adolescent circadian rhythm is delayed approximately 2 hours compared to before puberty. The circadian rhythm changes combined with the increasing prevalence of evening light exposure because of the excessive screen time during night commonly commonly leads to a delayed bedtime in typical adolescents. The physician should be encouraged. The physician should encourage the sleep hygiene and should not prescribe any sleep medication like zolpidem or any other medication. Okay, sleep hygiene is important. The patient should avoid screen time before bedtime, and no pharmacological indication is there here because only sleep pattern is same. Okay, sleep pattern is same, but 2 hours delay, which is normal because now the patient is moving towards adolescent phase. So, urine toxicology screening could assist in diagnosing substance use as a cause of insomnia. However, the patient's sleep pattern is normal and not consistent with insomnia. Over-the-counter medications such as antihistamines, zolpidem can be utilized for primary insomnia. However, this patient's sleep pattern is normal and not consistent with insomnia. Modafinil therapy is central nervous system stimulant commonly utilized to address daytime sleepiness in patients with narcolepsy, obstructive sleep apnea, and shift work sleep disorder. Though the patient has difficulty waking up, he does not experience daytime sleepiness. Okay, so modafinil is not required because it is a CNS stimulant. Again, educational objective after puberty, adolescent circadian rhythms are delayed approximately 2 hours. No pharmacotherapy is needed for this normal change. Well, moving to the next question. Question number 3. An asymptomatic 37-year-old woman come to the physician for a follow-up examination after an HIV antibody test was positive. So, HIV antibody test was positive. Her last HIV antibody test 5 years ago was negative. 5 years ago was negative, now it's positive. She has no previous history of sexually transmitted disease. During the past 10 years, she has been sexually active with 8 male partners. She uses an oral contraceptive. She does not know of any partners who are HIV positive. She exercises regularly. Her vital signs are within normal limits. Examination shows no abnormalities. CBB, complete blood count, serum electrolyte, urine nitrogen, creatinine concentrations are within the reference range. Her CD4 plus the T lymphocyte count is 410 per mm3. Normally should be more than or equal to 500. And plasma HIV viral load is 30,000 copies per ml. Urine pregnancy test is negative. Serological testing for hepatitis and a PPD skin test are negative. PPD skin test are negative. Liver function test showed no abnormalities. Antiretroviral therapy is begun. Which of the following is most appropriate next step to prevent infections in this patient? Fluconazole, isoniazid, pyrimethamine, sulfamethoxazole therapy or trimethoprim sulfamethoxazole therapy. Or 23, valent pneumococcal vaccine. See, pneumococcal vaccine should be given other than any drug. So, 23 valent pneumococcal or pneumococcal 23 valent polysaccharide vaccination is the most appropriate next step to prevent infectious complications in this patient with newly diagnosed HIV infection. There are 2 pneumococcal vaccines that are routinely given to patients certain health conditions or at particular ages. PPSP23 and the pneumococcal 13 valent conjugate. 13 valent conjugate vaccine PCV13. PCV13 or PPSV23. PPSV23 is indicated for all patients over the age of 65 regardless of underlying medical conditions, but is also given to patients between 19 and 60 with certain medical conditions. PCV13 is typically only given to patients with certain underlying medications, including medical conditions including HIV infection, lymphoma, leukemia, multiple myeloma, functional anatomic, asplenia, end-stage kidney disease, cochlear implants, cerebrospinal fluid leaks, a history of solid organ transplant, and congenital or acquired immunodeficiencies among several other conditions. In this patient, PCV13 vaccine should be given first, followed by PPSP23 vaccine at least 8 weeks later. Revaccination with PPSP23 should occur again 5 years after the first dose. So incorrect options are A, B, C, and D. Fluconazole, isoniazid, pyrimethamine sulfamethoxazole, and trimethoprim sulfamethoxazole therapy is not required. Okay, so here fluconazole therapy choice is indicated to treat candida infection. Azole, this is a azole. Azole is a antifungal. So antifungal antibiotic. Okay, it is antifungal. It is antifungal. It is indicated to treat candida infection because in immunocompromised patients it occurs. So, treat candida infections in patients with HIV infection. Okay. Although these infections rarely occur in patients CD4 counts above 100 cells per mm3. If CD4 counts are above 100 cells per mm3, not required. Okay. This infection do not occur. The patient has no evidence of candida infection, does not require treatment or prophylaxis. If the patient is not having CD4 count is above 100, fluconazole treatment is not required. Isoniazid therapy is used to treat latent Mycobacterium tuberculosis infection latent. After ruling out active tuberculosis, it requires combination therapy. The patient has a negative TPD skin test in setting of a relatively normal CD4 count. Effectively rules out the latent tuberculosis. So TPD skin test is negative, means no latent tuberculosis. So this is not indicated. So isoniazid not indicated. Pyrimidine and sulfamethoxazole therapy is not indicated in this patient. This is for malaria actually. This combination is for malaria. It is not indicated in patient either pyrimethamine with sulfadiazine or trimethoprim sulfamethoxazole can be used to prevent toxoplasmosis, because toxoplasmosis is very dangerous. So, but the combination of pyrimidine and sulfamethoxazole is not typically used. Prophylaxis is indicated once the CD4 plus T cell count falls below 200, then prophylaxis is indicated. Below 200, then prophylaxis is indicated. For toxoplasmosis, either pyrimethamine, either pyrimethamine with sulfadiazine should be there. Sulfadiazine, not sulfamethoxazole, sulfadiazine with pyrimethamine or trimethoprim with sulfamethoxazole. This combination, pyrimethamine with sulfadiazine should be there, or sulfamethoxazole with trimethoprim. This combination should be there. Pyrimethamine with sulfadiazine or sulfamethoxazole with trimethoprim. Okay, this combination of toxoplasmosis prevention can be given, but if CD4 is not below 200, prophylaxis is not required. Okay. Educational objectives. Patients with HIV infection and other immunocompromising conditions should receive both pneumococcal vaccine. The Center for Disease Control recommends administering PCV13 first in patients with HIV, followed by PPSV 3 at least 8 weeks later. Okay. So, which vaccine should be given? Pneumococcal vaccine. First, PCV13, because PCV13 is given with medical complications patient, like renophilia, leukemia, organ transplant, cochlear implant. In such patient, first PCV13 is given, then should given first, followed by PPSV23 after 8 weeks. After 8 weeks, revaccination with PPSV23 should occur again after 5 years. So, pneumococcal vaccine should be given. Okay. Next question. Moving on to next question. Are you excited? Let's see this question. A 27-year-old woman comes to the physician because of a 1-week history of progressive left-sided weakness. Weakness she's having. Okay. Weakness is the main complaint she's having. Weakness. 6 months ago, she underwent an uncomplicated pancreatic transplant. She undergone a pancreatic transplant. To be noted, because of type 1 diabetes mellitus. Her conditions are, her medications are mycophenolate, mofetil, and prednisolone. She's on prednisolone. Okay, steroid. Vital signs are within normal limits. Muscle strength 4/5 in left lower aspect of the face, and left upper extremity. Deep tendon reflexes are increased on the left. Sensation is intact. The remainder of the examination shows no abnormalities. MRI of the brain shows a homogeneously enhancing right frontotemporal mass. Homogeneously enhancing right frontotemporal mass with surrounding edema is there. very serious condition. A biopsy specimen of the lesion shows proliferation of monoclonal B lymphocytes. So the most likely causal organism. So it is Epstein-Barr virus. Here, brain shows a homogeneously enhancing right frontotemporal mass. Frontotemporal mass. Because she was on steroid. Okay, and edema is there. Okay, and monoclonal B. Most important, monoclonal B lymphocytes in biopsy. Okay, now moving to the explanation. Epstein-Barr virus is a commonly indicated pathogen in the development of post-transplant lymphoproliferative disorder (PTLD). So EBV is a common inciting pathogen in the development of post-transplant lymphoproliferative disorder (PTLD). Okay, a condition that occasionally affects individuals solid organ transplant or stem cell transplant who remain on high doses of immunosuppressant medications. Primary EBV infection is exceedingly common and present commonly as mononucleosis in immunocompetent patients. The virus primarily infects B lymphocytes. B lymphocytes, the virus primarily infects B lymphocytes which present viral antigens on the surface, leading to T lymphocyte stimulation, subsequent destruction of affected B lymphocytes. Some infected cells, however, are able to evade immune surveillance and persist in the host. In patients receiving high doses of immunosuppressive medication, those whose T lymphocyte population has been ablated, the loss of T lymphocyte surveillance allows the proliferation of B lymphocytes that continue to harbor the virus. This can lead to PTLD. Clinical manifestation vary greatly and depend primarily upon the location in which the infected B lymphocytes replicate. Up to half of the patient present was discrete extranodal mass. Treatment always includes reduction of immunosuppressive medication and depending upon severity may also include the use of rituximab with antiviral rituximab with or without classical B lymphocyte lymphoma regimens. Cytomegalovirus can cause a mononucleosis-like syndrome in immunocompetent patients but cause a variety of other diseases in patients who are immunodeficient, including esophagitis, rhinitis, pneumonitis, colitis, that is not frequently the cause of pathogen identified in PTLD. Human herpes virus 6 can cause pneumonitis, myelitis, encephalitis, hepatitis in transplant recipient. However, is unlikely to be the causative agent because it causes several things like pneumonitis, myelitis, encephalitis, hepatitis in transplant patient recipients. JC virus causes progressive multifocal leukoencephalopathy. Multifocal leukoencephalopathy condition in which patients after solid organ or bone marrow transplant as a result of reactivation JC virus. Classical clinical features include ardor mendacious diplopia, double vision, seizures, ataxia, and motor deficits. Pathologic specimens should show demyelination, not as monoclonal proliferation of B lymphocytes. So JC virus demyelination. JC virus shows demyelination. What happened to this pen? JC virus shows demyelination. Okay. Human herpes virus 6, it shows different symptoms like hepatitis, pneumonitis. CMV mononucleosis-like symptoms can be there in immunocompetent patients as well. In immunodeficient patients, esophagitis, rhinitis, pneumonitis, colitis, all these can be there. Talking about varicella zoster virus commonly causes family infection in children, but reactivation later life painful eruption of vesicular lesions are there. Vesicular lesions within one or two adjacent dermatomes. Patients who are immunosuppressed can sometimes develop this disseminated zoster infection, but this patient's brain mass is not typical of this disease. So, Varicella zoster cannot be the option because in this painful vesicular lesions are present on the skin, and it is based on dermatomes along the dermatomes. Education objectives PTLD may occur in patients after solid organ or stem cell transfer as a result of reactivation of latent EBV infection. Because symptoms depend upon the location of the subsequent B lymphocyte mass and treatment involves descalation of immunosuppression with or without rituximab and regimen for primary B lymphocyte neoplasms. So here, this case is a very interesting case. Here, the patient after transplant is having some complications because of the Epstein Barr virus. So Epstein Barr virus is showing homogeneous enhancing right frontotemporal mass, and proliferation shows monoclonal B lymphocyte. This is very important. Monoclonal B lymphocyte proliferation is there because what happens in this infection? This is post-transplant lymphoproliferative disorder, and high dose because of high doses of immunosuppressants like prednisolone. Okay, primary EBV infection is exceedingly common and presents commonly as mononucleosis in immunocompromised patients. The virus primarily infect B lymphocytes, which present viral antigens on the surface into T lymphocyte stimulation with subsequent destruction of the affected B lymphocytes. So infected cells, however, are able to evade immune surveillance and persist in the host. In patients receiving high-dose immunosuppressive or those who lymphocyte population has been ablated, loss of T lymphocyte surveillance allows the permission of B lymphocytes continue to harbor the virus. This can lead to PTLD, post-transplant lymphoproliferative disorder. Clinical manifestations vary greatly and depend primarily upon the location in which the infected B lymphocyte replicates. Up to half of the patients with discrete extranodal mass treatment always includes reduction in immunosuppressive medication, and depending upon the severity may include extranodal mass treatment always includes reduction of immunosuppressive medication, and depending upon the severity may also include the use of rituximab with or without classic B lymphocyte lymphoma regimen. B lymphocyte lymphoma regimen. So mononucleosis was the monoclonal B lymphocytes. I hope you are enjoying the session. Next question. Next question. A previously healthy 52-year-old. Okay. A previously healthy 52-year-old woman is brought to the physician because of 1 month history of progressive fatigue and low back pain. So the age of the patient is 52 years. 52 years woman. 1 month history of the chief complaint is progressive fatigue and low back pain. Vital signs are written normally with examinations with diffuse tenderness to first percussion over the lumbar spine. Laboratory study shows. So hematocrit is 30%, leukocyte count 9,500. Okay, segmented neutrophil 65, band 5, lymphocytes 10, monocytes 20, platelet count 2 lakhs, serum calcium, urine nitrogen in protein. A protein electrophoresis shows monoclonal gammopathy. X-rays of the back shows severe osteoporosis of the lumbar and thoracic spine with fracture. Without fracture, there is no fracture. Okay, examination of the bone marrow shows sheets of plasma. The cytogenetic analysis of the bone marrow shows no markers which are the following most likely to be increased in this patient. So monoclonal B lymphocytes. So monoclonal B lymphocytes are the most likely cell type to be increased in this patient with probable multiple myeloma because plasma cells are increased. While a monoclonal gammopathy and spike may occur in a variety of B lymphocyte malignancies, including Waldenström, macroglobulinemia, plasma cell leukemia, smoldering myeloplasma, amyloidosis, or plasmacytoma. It is most commonly recognized in the setting of multiple myeloma. Other signs and symptoms of multiple myeloma include bone pain, Patient may have bone pain, anemia, hyperkalemia, kidney dysfunction, and lighted bone lesions, many of which apparent in this patient. B lymphocytes are precursors to plasma cells, which secretes specific immunoglobulins, different classes, and are considered terminally differentiated B lymphocytes. Multiple myeloma is the malignancy caused by neoplasticization of a single plasma cell clone which overproduces monoclonal immunoglobulin and light or heavy chains. These clonal immunoglobulins are sitting in high numbers and appear as monoclonal spike over presence of on protein necrophysis in gamma region on protein necrophysis diagnosed multiple analysis structure based on the presence of M protein spike in the presence of concerning symptoms, but it is confirmed by bone marrow biopsy, which must demonstrate at least 10% clonal plasma cells. Erythroid stem cells give rise to erythrocytes, which can increase in number in conditions such as polycythemia vera. So this option, erythroid stem cell. So erythroid erythroid red blood. So it gives rise to erythrocytes, red blood cells. So increase in number of red blood cells to polycythemia vera. In conditions polycythemia vera. Megakaryocytic stem cells are the precursor of platelets and are not increased in patient with multiple myeloma. So in many instances, displacement of normal bone marrow cells from malignant plasma cells can lead to thrombocytopenia. So in many instances, displacement of normal bone marrow by malignant plasma cells can cause a decrease in platelet count, thrombocytopenia. Here the platelets are not increased, but they are on the lower side only. Monoclonal T lymphocytes expansion defines T cell lymphoma, but would not be suspected in a patient with multiple myeloma, which is a disease of differentiated B lymphocytes. Multiple myeloma is having differentiated B lymphocytes. Monoclonal T lymphocytes have T cell lymphoma, but here not T cell lymphoma, we have B lymphocytes. So here if you see, here T lymphocytes, there is not issue with the T lymphocytes. Here plasma cells. Multiple myeloma, which is a disease of differentiated B lymphocytes. Differentiated B lymphocytes are the problem. If you see the bone marrow, you can see sheets of plasma cells. You can see the sheets of plasma cells. This is definitive of multiple myeloma. Bone marrow have, if 10% are there, then you can confirm it is multiple myeloma. Okay. So non-differentiated patient with multiple myeloma, which is a disease of differentiated B lymphocytes. Myeloid stem cells may become malignant through various mechanisms, ultimately resulting in the development of acute myeloid leukemia. Patients with this condition which would have myeloblasts apparent on peripheral blood smear. But here no myeloblasts are there and peripheral blood smear, okay, PBS. Pluripotent stem cell describe a population of cells that has the potential to become numerous different types of differentiated cells. Multiple myeloma is a disease of B lymphocytes which are already differentiated. So polyclonal B lymphocytes are often found in increased numbers of in response to viral infections. Polyclonal B lymphocytes. is defined by monoclonal population, not a polyclonal population of B lymphocytes. It's the monoclonal B lymphocyte differentiated. Okay. Polyclonal T lymphocyte incorrect because as in multiple myeloma, it's concentration of monoclonal B lymphocyte, not T lymphocytes. So it is not T, it is B. An unspike denoted a monoclonal concentration of immunoglobulin raised secreted from a population of monoclonal plasma cells. While N spikes are encountered in several malignancies, they are most commonly seen in multiple myeloma, which is a disorder of clonal plasma cell proliferation. Plasma cells are terminally differentiated B lymphocytes, and thus this is considered B lymphocyte malignancy. So if you see here, once again I'll pick this. So monoclonal B lymphocytes are most likely cell type to be increased in this patient, probably with probable multiple myeloma. While a monoclonal gammopathy and spike may occur in a variety of B lymphocyte malignancies, including Waldenström, macroglobulinemia, plasmacytolemia, smoldering myeloma, amyloidosis, or plasmacytoma. It is most commonly recognized in the setting of multiple myeloma. Other signs and symptoms of multiple myeloma include bone pain, anemia, hyperkalemia, kidney dysfunction, and lytic bone lesions. Some of which are apparent in this patient. B lymphocytes are precursor to plasma cells. B lymphocytes are there now. These are precursor to plasma cells. B lymphocytes are precursor to plasma cells. B lymphocytes are precursor to plasma cells. Okay. Which secrete specific immunoglobulins of different classes are considered terminally differentiable B lymphocytes. MM is the multiple myeloma, the malignancy caused by neoplastic of single plasma cell clone, which overproduces monoclonal immunoglobulin in light or heavy chain. These clonal immunoglobulins are secreted in high number as appears as the monoclonal spike of protein electrophoresis in the gamma region of protein electrophoresis. High numbers immunoglobulins are there, so gamma is raised in electrophoresis. Diagnosis multiple myeloma is suspected based on the presence of M protein spike in presence of concerning symptoms, but it is confirmed by bone marrow biopsy, which shows demonstrates 10%, at least 10% clonal plasma cells. Next question. A 22-year-old woman, she comes to the physician because of a 2-week history of yellowing skin and increasing shortness of breath on exertion. Duration is 2 weeks. Complaints are yellowing skin, increased shortness of breath on exertion. She has not had abdominal pain or weight loss. She does not smoke cigarette or use illicit drugs. She drinks 2 beers on weekend. Her pulse is 80 per minute, respiration 12 per minute, blood pressure 100 by 70 mm. Examination shows clearance, icterus, and jaundice. The lungs are cleared to auscultation. Abdominal exam shows a lever span of 10 cm and spleen tip is palpated 3 cm below the cleft costal margin. The remainder of the examination shows no abnormalities. Her hematocrit is 20%, reticulocyte count is 10%. Visual serum studies are most likely to show the following. Let's see. Indirect bilirubin should be high, lactate high, alkaline phosphate should be decreased because of the liver damage. So increased concentration of indirect bilirubin and lactate is a normal levels of alkaline phosphate would be expected in this patient who has a significant consistent with hemolysis. She is having hemolysis actually. Lactic count is low. Hemolysis describes the process whereby erythrocytes undergo cell lysis, and it may occur either intravascularly with the release of free hemoglobin into circulation or extravascularly within spleen and reticular endothelial system with the action of macrophages. Free hemoglobin is broken down into iron and heme, is further reduced to biliverdin and then unconjugated. So increased concentration of indirect bilirubin and lactate in with normal levels of alkaline phosphate will be expected in this patient who has a clinical presentation consistent with hemolysis. Okay. Hemolysis describes the process whereby erythrocytes undergo cell lysis, and it may occur either intravascularly where free hemoglobin will be released. Into the circulation, or extravascularly within the spleen and reticular endothelial system through the action of macrophages. Free hemoglobin is broken down into iron, heme is further reduced to bilirubin and then to unconjugated, that is indirect bilirubin. So increased erythrocyte turnover leads to increased concentration of indirect bilirubin. LDH is also present in large concentrations within erythrocytes. the dehydrogenase. So the erythrocytes for hemolysis also leads to increased concentration of LDH. So hemolysis also leads to increased concentration of LDH. Furthermore, the subsequent anemia, because the erythrocytes do not have mitochondria, so the energy is produced by lactate dehydrogenase. So that after erythrocytes are breaking down, the LDH is released into circulation. So LDH is increased. Furthermore, the subsequent anemia that develops as a result of hemolysis induces the bone marrow to increase production of erythrocytes and stimulate the release of immature cells, also known as reticulocytes, into circulation. Normal concentration of indirect bilirubin, LDH and ALP choices would be expected in patients without hemolysis or biliary obstruction. Normal if indirect bilirubin is normal, LDH and ALP are normal, means the patient is not having hemolysis, the patient is just having biliary obstruction. Normal concentration of indirect bilirubin and LDH with increased ALP suggests of intrahepatic or extrahepatic biliary obstruction. Intrahepatic or extrahepatic measurement of conjugated direct bilirubin would be useful again in such a situation, as this would be increased in case of biliary obstruction. If direct is means biliary obstruction. If intrahepatic or extrahepatic biliary obstruction is there, this both will be increased, this both will be normal, ALP will be increased. Normal indirect bilirubin and ALP. Normal indirect bilirubin and ALP increased LDH is not specific but seen in malignancy or infection. Normal indirect bilirubin with increased ALP and LDH not suggestive of hemolysis but with suggestive of malignancy. Increased concentration of indirect bilirubin with normal LDH and ALP are seen in benign liver conditions such as Gilbert syndrome. Indirect bilirubin normal, LDH is increased, ALP is increased means no. If indirect bilirubin is just increased, LDH is normal and ALP is also normal, means it is Gilbert syndrome. There is no hemolysis, no obstruction, but it is Gilbert syndrome. This is from a deficiency in the enzyme required to conjugate bilirubin. Conjugate the bilirubin, there is deficiency of the enzyme because of that. Increased concentration in indirect bilirubin and ALP with normal LDH, biliary obstruction would be necessary. Increased levels of indirect bilirubin, LDH and ALP can be seen in a variety of conditions. So measurement of additional markers such as hepatoglobin, liver-associated enzymes, gamma-glutamyl transferase and conjugation tests will be useful to further delineate the cause. Hemolysis can occur within the vessels, intravascular. Hemolysis can occur within the vessel, that is intravascular. Can occur within the vessel intravascular, reticular endothelial system, or extravascular, or in both. Extravascular hemolysis commonly results in splenomegaly as seen in this patient. Patients with hemolysis present with varying degrees of anemia and reticulocytes in addition to cytosine in addition to increased concentration in dark bilirubin and LDH. Dark bilirubin ALP, both of which are increased instances of biliary obstruction should be normal. Dark bilirubin and ALP, both of which are increased in instances of biliary obstruction. It's a normal in this case. Should be normal, okay? Next question. So I have a lot of questions. See. It's very interesting. Let's just start some random questions and do it. Let's do this one. So we have approximately we have 50 questions. Let's do the last one. A previously healthy 24-year-old woman is brought to the emergency department because of severe abdominal pain she is having since 4 hours. The pain began after she ate lunch following an aerobic class. She is not sexually active. Her temperature is 38.2 degrees Celsius and pulse 120 per minute. Abdominal examination shows left lower quadrant tenderness. Left lower quadrant tenderness means something near the appendix, and rebound, not appendix, sorry, okay, not appendix, and rebound to deep palpitation. Pelvic examination shows an ex- exquisitely tender left ovary. Ovaries might be affected with fallopian tube, but she's not actually active. Na? Tender left ovary with the fallopian tube rupture. There is mostly say ectopic pregnancy. She's not sexually active, so something with the ovary. The introitus is normal. There is no discharge in the vaginal wall and no cervical motion tenderness. Leukocyte count is 15,300. Segmented neutrophils, eosinophils, monocytes. Urine analysis is within normal limits. In addition to measurement of serum, beta HCG concentration is most. Okay, next step in diagnosis: transvaginal ultrasonography. You see ovaries well, and ectopic pregnancy. Ovarian torsion can be done. Severe acute abdominopelvic pain in a woman of childbearing age with a locally tender ovary should raise suspicion for ovarian torsion, ruptured ectopic pregnancy, PID, pelvic inflammatory disease, and ruptured ovarian cyst. In addition to emergency gastrointestinal, vascular, and urological differential diagnosis, female pelvic anatomy is best. Image for these purposes with pelvic ultrasonography, which provides X-ray resolution images of the ovaries, fallopian tube, uterus, bladder, and pouch of Douglas, while also permitting Doppler analysis of vascular flow, which is crucial when ovarian torsion is suspected diagnosis and go for Doppler analysis. Ovarian torsion results when the ovary twists about itself within the broad ligament. Within the broad ligament, ovarian torsion results when the ovary twists about itself within the broad ligament. Ovary twist within the broad ligament. Ovary twist within the broad ligament. Ovary twist within the broad ligament. Okay. Okay, fine. The ovary twist against broad ligament. Torsion results when the ovary twists within the broad ligament and which results in constriction and impingement of the venous and arterial supply. Edema, ischemia, and infarction can result in the torsion is not promptly surgically reduced. Ultrasonographic signs of ovarian torsion include reduced or absent Doppler flow in the return of gonadal arterial supply, absence or reduction of vascular flow in the ovarian stroma, ovarian edema, and hypoechoic fluid surrounding the ovaries. Okay, retrogradal arteries, the absence of reduction of vascular flow within the ovarian stroma, ovarian edema, hypoechoic fluid surrounding the ovary, and in absence and ovarian follicles displaced to the outside of the organ. A large ovarian cyst more than 5 cm suggests a cause of torsion. Treatment includes pain control plus surgical reduction of torsion. In this example, additional differential diagnosis to consider include pelvic inflammatory disease and tubo-ovarian abscess, the basis of patient's fever, and leukocytosis. Less likely given an absence of sexual activity. So a large ovarian cyst more than 5 cm suggests a torsion, cause of torsion. Treatment includes pain control, surgical reduction of torsion. In this example, additional differential diagnosis to consider include pelvic inflammatory disease (PID) and tubo-ovarian abscess on the basis of patient's fever, leukocytosis. Though these are less likely given absence of sexual activity, inconsistent examination, ruptured ectopic pregnancy, or ovarian cyst. Any of these differential diagnoses are appropriately evaluated on ultrasonography, making the most appropriate next step. Next. I think I should turn it in this. It's not going to turn. I don't know why. So, X-ray of abdomen may be used for evaluating bowel gas pattern, obstruction, malrotation, valvulus perforation, or nephrolithiasis. Among other diagnoses, it does not provide sufficient soft tissue imaging when evaluating the pelvis, and pelvic organs are obscured by the surrounding bony pelvis. Hysterosalpingography is used to evaluate the lumen of the uterus and fallopian tubes, useful in assessing for polyps, synecdoche, adhesions, malignancy, strictures, and is often employed in the evaluation of malignancy or infertility. Would not reasonably evaluate an ovary. CT scan of the abdomen is a reasonable choice to evaluate the abdominal pelvic organs. However, it does not permit direct assessment of vascular flow to an ovary. Only indirect signs of ovarian torsion would be present, such as displayed follicles, presence of cyst tumors, torsions, ovarian tumors, edema. Vascular flow, indirect, such as displaced follicles, presence of cyst or tumors, ovarian edema. CT scan is a reasonable choice when the differential is less focused on ovarian pathology. Example, if nephrolithiasis or diverculosis was likely. Okay. Kuldocentesis is generally outdated technique to sample fluid from the pouch of Douglas via transvaginal approach. Given the ability of rapid and advanced imaging such as CT scan and ultrasonography has largely been the setting with these models not available. Ultrasonography is an excellent modality which to evaluate female pelvic anatomy and its permits post-structure vascular anatomic and functional assessment. It is to study when ovarian tubular uterine pathology is high on the differential. Okay, the time we have to go for that. So let's move on to the next. A 57-year-old man is brought to the emergency department by his wife because of a 3-year history of progressive lethargy. So he's having lethargy. He has a 5-year-old history of myasthenia gravis. Oh my god. The hysterectomy did not improve his symptoms. He has smoked 1 pack of cigarette daily for 30 years and drinks 1 glass of wine daily. Current medications include prednisolone and azathioprine. On arrival, he is lethargic and difficult to arouse. Prednisolone and azathioprine. Okay, on arrival, he is lethargic and difficult to arouse. Examination marked bilateral ptosis. Ptosis is there, which is very suggestive of myasthenia symptoms. Bilateral ptosis will be there in myasthenia. Breast sounds slightly decreased with no wheeze or crackles. Arterial blood gas analysis on room air shows pH 7.19. Okay. PCO2 70 mm Hg, PO2 70 mm, bicarbonate 25. Correct answer. Whether it is. Hello? Okay. So, acute respiratory failure, chronic respiratory failure with an acute exacerbation, metabolic acidosis, metabolic hypertension. The patient with myasthenia gravis is a prolonged smoking history is likely experience acute respiratory failure both the basis of the clinical history and the analysis of his blood gases. Myasthenia gravis is an autoimmune condition in which antibodies result in destruction of acetylcholine receptors at the neuromuscular junction. Fewer receptors at the junction limits cholinergic signal transmission, which is vital for muscle contraction. This is to pause skeletal muscles, including the intercostal muscles and diaphragm. In addition to classic symptoms such as progressive muscle weakness and ptosis, patient may experience myasthenia respiratory crisis, especially in settings of increased respiratory demand. Obstructive lung disease, infection, sepsis, sympathetic stimulus. Okay, when patients are unable to ventilate because of impaired chest wall mechanism, acute retention of carbon dioxide results, which can cause an potentially acute or chronic respiratory acidosis, as seen in this patient. Respiratory acidosis. See, when patient are unable to ventilate because of impaired chest wall mechanism, acute retention of carbon dioxide results, as seen in this patient. Because the patient is not able to throw out carbon dioxide is accumulating in him, causing respiratory acidosis. Because the muscles cannot work properly because of acetylcholine receptors are few in myasthenia, carbon dioxide retention will be causing respiratory acidosis. Additionally, ventilation perfusion mismatch can result in hypoxemia, also seen in this patient. Analysis of blood gas, increased carbon dioxide and decreased respiratory causes present. In acute respiratory acidosis, pH falls approximately 0.08 mmHg for every increase in PCO2 by 10 mmHg. For example, PCO2 is 30 mmHg above normal, which indicates that the pH should fall by 3, that is 0.24 mmHg, that below 7.4. Patient pH in acute respiratory should be on compensation should prompt investigation for second, third metabolic and respiratory acid-base derangement. In this case, it may be reasonable to suspect a small metabolic acidosis caused by hypoxia, driving lactate production in addition to the respiratory. However, this is not demonstrated by the data. Carbon dioxide irritation is a classic cause of depressed mental status, respiratory failure known as carbon dioxide narcosis. Treatment includes mechanical ventilatory support, bilevel positive air pressure, intubation with mechanical ventilation, and cholinergic medications, pyridostigmine. Chronic respiratory failure is incorrect. In chronic respiratory failure, the pH falls by approximately 0.03 mmHg, but here we have 0.08. So 0.03 mmHg for every increase in PCO2 by 10 mmHg. In this previous case, acute 0.08 mmHg, the increase in PCO2 by 10 mmHg. Here 0.03 mmHg for every increase in PCO2 by 10 mmHg. This example, PCO2 is 30 mmHg above normal. In this example, 30 mmHg above normal, which indicate that the pH should fall by 3 into 0.03, that is 0.09 mm below 7.4. Here 0.24 mm. This patient pH is 7.19. 7.19. If his respiratory failure were chronic, this patient pH is 7.19. If it was chronic, then it should be 7.4 minus 7. Minus 0.09 should be 7.31. The actual pH should be 7.31. But here in this case, 19 is there. Because it is not chronic. The pH is way lower than that. In this case, if you see 7.4 minus 0.24, 7.16. It means the patient is having acute, not chronic. This is caused by this chronic respiratory failure. This is caused by kidney compensation for chronic carbon dioxide retention. Similarly, in chronic respiratory failure with an acute exacerbation, pH generally falls by an amount between 0.3 to 0.8 Hg for each 10 mm Hg increase in PCO2. For the patient with chronic respiratory failure, retain carbon dioxide as bicarbonate. Nearly normal even in exacerbation, which is again by chronic or acute on chronic component of disease. So here compensation is not there by kidneys. That's why it's acute, not chronic. If it might be chronic, then bicarbonate level should be high. For the patient chronic respiratory failure, retain carbon dioxide as bicarbonate. This patient bicarbonate concentration is nearly normal even in exacerbation. It means that it is not chronic, it is acute. It is acute. Kidneys are not compensating for it. So if chronic is there, the kidney compensation of carbon dioxide retention should be there. So when chronic respiratory failure with an acute exacerbation, pH generally falls by an amount between 0.3 to 0.8 mmHg for each 10 mmHg increase in PCO2. Further, patient with chronic respiratory failure retain carbon dioxide as bicarbonate, but this patient's bicarbonate is normal. Metabolic acidosis is incorrect as bicarbonate and PCO2 both decrease in metabolic acidosis outside of multiple derangements. So in metabolic, both should be decreased. Bicarbonate should be decreased, PCO2 should be decreased. Metabolic alkalosis is incorrect in the patient because pH is less than 7.35. pH is less. If the pH is more than 7.45, then it is alkalosis. But here pH is less than 7.45. It is even less than 7.35. And it is not alkalosis, it is acidosis. The normal pH is 7.35 to 7.45. Okay, fine. Educational object acute respiratory cell pH falls by approximately 0.08 mmHg for every increase in 10 mmHg. Acute respiratory is common complication of hypoventilation. As in case of myasthenia respiratory crisis. It's a good case, okay? Further, hospitalized 22-year-old woman, acute myelogenous leukemia, undergoes evaluation prior to discharge. She has received induction chemotherapy and injections via subcutaneous central venous catheter for the past 4 weeks. 2 days ago, results of a complete blood count and bone marrow biopsy shows no abnormalities. So, 22-year-old woman is there. She's having acute. Zoom it. Okay, a 22-year-old woman with acute myelogenous leukemia. She's having myelogenous leukemia. She's undergoing evaluation prior to discharge. She has received induction chemotherapy transfusion via subcutaneous central venous catheter the past 4 weeks. 2 days ago, results of a complete CBC, the complete blood count and bone marrow biopsy showed no abnormalities. Examination shows a well-healed skin over the catheter. Remainder of the examination shows no abnormalities. Physician used the patient's discharge plan with her and her parents. Which of the following is the most appropriate recommendation to avoid complications related to catheter? So actually they're asking about catheter. So appropriate recommendation to avoid complications. Avoid bathing in a shower or bathtub. Most appropriate they are asking. Okay, hand washing with an antibacterial soap prior to contact with the catheter. Appropriate to avoid. Complications. To avoid complications, what should we do? So we should, yes, use antibacterial soap. Yes. Instead of a new sterile dressing at the site of access. First thing is use the hand washing. Hand washing is must and it's prior for every procedure, everything, okay? So the primary goal of central venous catheter maintenance are to prevent catheter-related infection. Catheter-related, central catheter-related infection. Catheter-associated blood infections. Okay. So we have to avoid this thrombotic complications, mechanical dislodgement, infection risk is reduced because this is central catheter, not a normal catheter. Central venous catheter. By minimizing the amount of time of catheter is accessed and exposed, routinely inspecting the catheter site, periodic changing the catheter dressing, and using aseptic technique while manipulating the catheter. Washing with an antibacterial soap prior to contact with the catheter is an essential step in practicing aseptic techniques and reducing the risk of infectious complications. Thrombotic complications can be reduced by using catheter lock solutions, routinely inspecting the catheter site, timely initiation and anticoagulation or catheter exchange if thrombus does develop. Exchange if thrombus develop. So this is very important. So timely initiation of anticoagulation or catheter exchange if thrombus does develop. Mechanical dislodgement can be arrested by securing the catheter with sutures. Okay, covering it with a dressing when not in use. Routinely inspecting the catheter site, avoiding sudden large movement while handling the catheter. Avoid bathing in a shower or bath tube. Is not necessary for routine maintenance of a central venous catheter. Avoiding bathing in shower or bathtub is not for routine maintenance of central venous. The care should be taken to keep the catheter side and dressing dry, but waterproof covers can be used, and the catheter should be clean, and the dressing change if it does become damp, loose, and visibly soiled. Okay, so it's important. Topical application of mupirocin at the site of access, and oral penicillin therapy as well as the other agents for local or systemic antibacterial prophylaxis are not necessary for routine maintenance of central venous catheter. Patients with limited venous access options who have a known line infection are at high risk for line infections and cannot have the catheter replaced may be managed with prophylactic or suppressive antibiotic under the guidance of infectious disease expert. Central venous catheter, especially when present for extended duration outside the hospital, are at risk of infectious thrombotic mechanical complications. Hand washing and appropriate aseptic techniques prior to manipulating the catheter and routine catheter site inspection are essential for minimizing the risk of complications. I hope the session was helpful to you. If so, we'll end up with this question. An asymptomatic 57-year-old woman comes to the physician for a routine health maintenance examination. She has smoked 1 pack of cigarette daily for 40 years. 1 pack of cigarette, oh my god. She drinks wines occasionally at social events. She takes vitamin D daily. Examination no abnormalities. Laboratory studies show calcium, urea, nitrogen, creatinine, phosphorus, parathyroid hormone related protein. An X-ray of the chest shows a 2 centimeter nodule in the right upper lobe of the lung. Which side of the lung not mentioned is most likely diagnosis. Smoke करना, squamous cell carcinoma of the lung. Squamous cell carcinoma of the lung is the second most common type of primary lung cancer after adenocarcinoma. Risk factors for all major types of lung cancer include tobacco use, second-hand smoke, asbestos or radon exposure, family history of lung cancer. Features of squamous cell carcinoma of the lung include pulmonary cavitation, central location, hypercalcemia caused by paraneoplastic parathyroid hormone-related peptide production. Histologic characteristics include polygonal cells with intercellular bridges, eosinophilic cytoplasm, keratin pearls, extensive necrosis. Lung cancer in general typically presents with cough, unintentional weight loss, hemoptysis, chest pain, dyspnea, hoarseness, occasionally wheezing, focal ronchi, or hypertrophic osteoarthropathy may be noted on examination. Diagnosis is made by chest imaging examination of a biopsy specimen. Diagnosis of a biopsy specimen. Biopsy specimen. Examination of a biopsy specimen. Prognosis is a function of the cancer type along with grading and staging of the disease. It is often detected once metastatic, at which point the prognosis is poor. Metastatic carcinoma of the colon, most commonly present with a change in bowel habits, rectal bleeding, weight loss. Oh my god. It commonly metastasizes to liver, lung, peritoneum. Metastatic lesions in the lung appear as randomly distributed pulmonary nodules. Colorectal cancer is not associated with PTHRP production or hypercalcemia. So, bowel habits, rectal bleeding, weight loss, metastasis to liver, lung, peritoneum. Lung typically appears randomly distributed pulmonary nodules. Hypoparathyroidism is most commonly caused by parathyroid adenoma, parathyroid hypoplasia, and parathyroid carcinoma. Hormone result in hypercalcemia. Serum intact PTH concentration, undetected PTHRP would be expected. Sarcoidosis is a non-caseating granuloma. Disease that often involves the lungs, non-caseating. Presents with shortness of breath and cough. Hypercalcemia with unregulated vitamin D synthesis. Diagnostic imaging findings include skeletal higher limb adenopathy with or without bilateral upper lobe predominant tissue. The patient's history of tobacco use increase solitary lung nodule and X-ray. History primary lung cancer. Small cell of lung is a neoplasm of neuroendocrine cells associated with numerous paraneoplastic syndrome in appropriate antidiuretic hormone Lambert-Eaton myasthenic syndrome caused by presynaptic calcium channel antibody production. Paraneoplastic membrane encephalitis and subacute cerebellar degeneration, hypercalcemia, and PTHRP production associated with squamous lung cancer. Centrally located primary lung cancers include squamous cell carcinoma of the lung and small cell carcinoma of lung. Squamous cell carcinoma is more common subtype as associated with hypercalcemia caused by PTHRP production. Parathyroid hormone related protein should be less than 1.3, but in this patient it is 12 p-mole per liter. Squamous cell lung carcinoma, second most common type after adenocarcinoma. So it is mostly associated with hypercalcemia and solitary nodules. See, features this is squamous cell carcinoma of lung include pulmonary cavitation, central location, hypercalcemia caused by paraneoplastic parathyroid hormone related peptide. Squamous cell of the lung includes pulmonary ventilation, central location, hypercalcemia caused by paraneoplastic parathyroid related hormone. Polygonal cells, intercellular bridges, snowflake site of a keratin pulse because it is squamous cell, extensive necrosis. Cough, weight loss, hemoptysis, chest pain, dyspnea, hoarseness.